everyone. Hope you can hear me. We had a pretty math-heavy morning. Warning, there is some math in this lecture, so I'll try to make it as unmath as possible, so you don't have to hurt your brains too much. All right. So with that caveat, today I'm going to be presenting on fluid resuscitation ultrasound. I'm just going to take this mask off. All right, so okay, to start off, I'm going to put a math diagram in front of you. Don't freak out. This is called the Frank-Starling curve. You might remember it from way back in med school when you had to learn this at some point. But basically, this is sort of the curve that you want to look at with your preload and your stroke volume. And basically why we care about this is we want to know where someone sits on this curve to know whether they are fluid responsive or fluid non-responsive. This is pretty important if you're doing fluid resuscitation, especially in higher risk groups where over resuscitation would be harmful to them. For example, people with renal failure or heart failure, those are the people that you may hesitate for shotgunning any sort of fluid resuscitation strategies. So we're going to go over different components of this. The first part is to look more towards the left of the graph, where your curve is going a little bit more steeply upwards, and that indicates that someone is in the fluid responsive part of the curve, where there's still room to give more fluid, and therefore you've got a little green light to go. Then you get towards the right side of the curve, where they're less fluid responsive or fluid non-responsive because their tank is already almost full. And you don't want to give them more fluid if they're in this part of the curve, otherwise risk fluid overloading them. And that can cause significant morbidity and mortality, and especially those sensitive population groups. All right, so how does this relate to ultrasound? Thinking about how we use ultrasound to measure fluid status and fluid responsiveness, this is probably the most common, or what comes to mind, I think, for most people. When you want to be like, well, should I give this person fluid? A lot of people, their go-to is to look at the IVC. This is probably the most well-studied out there, but the data is sort of hit or miss. From all the articles that I've read, it sounds like if you have a patient that's the perfect sort of characteristics of not any confounding like abdominal pressure, not any confounding lung pressure, your probe is in the exact same, the correct position, and you, by pushing the probe into that patient's like subxiphoid area, are not also increasing the patient's intra-abdominal pressure, you will probably get an accurate IVC collapsibility measurement. Otherwise, maybe not. So that's a limitation in there. Of note, this is sort of a single picture that you can take, and you can just say, at this point, this is a snapshot of their fluid status. The next thing I want to bring up is LVOT VTI. Lots of acronyms here. This may be familiar to the more ultrasound savvy, and seems to be the next big thing coming out in terms of fluid resuscitation. This is a dynamic measurement where you have to measure this before and after an intervention, usually like a 500 cc bolus, or a substitute for that. That's done in a lot of studies, the passive leg raise, kind of sort of flip someone onto their back and lift their legs up, and that simulates a 500 cc bolus. Thirdly, something called carotid flow time. I think this is more on the cutting edge, and there's just now emerging evidence on this. But it isn't really well studied yet to make any conclusions at this point. So today's lecture is going to focus on LVOT VTI. So what is VTI? VTI stands for velocity time integral. That's just another fancy name. Basically, it's something that cardiologists tend to look at to figure out stroke distance, stroke volume, and they're looking at basically the blood flow across a valve during a cycle of closing. We don't really care about that in the fluid resuscitation setting. We just want to see how it changes before and after a fluid bolus so that we can figure out if someone is fluid responsive. So if you care about all the cardiology stuff, you can get into that. But for the purpose of this lecture, we're only going to talk about this application to fluid responsiveness. Okay? So not to scare you, there's a lot of like math and numbers on this slide, but some things that I want to highlight essentially is that the two things that we can measure with ultrasound are the LVOT diameter, which stands for the left ventricular outflow tract diameter, and the VTI, which is the velocity time interval. So those are the two things that you'll be able to look at through ultrasound, taking those numbers, then you can do all these fancy math calculations to figure out what you want, okay? And then I'm going to give you that the LVOT diameter is constant regardless of your fluid status. Therefore, when you go back to all these equations, you don't even need to measure that. You don't even need to calculate the aortic area. And all you really need to measure is the VTI. And that will remain proportional. The change in your VTI will remain proportional to your change in stroke volume, which is what you're looking for to put your patient on that Frank-Starling curve. Everyone still with me? Anyone lost? Confused? All right, we'll get back to this. Going with the probe. Any idea which probe we're going to use? We're going to use the phased array cardiac probe. I put this slide in there just for completion's sake. Again, for the purpose of fluid responsiveness, don't need to calculate your left ventricular outflow tract diameter, but if you were interested in doing it, you would want to do it in the peristernal long axis view. You want to do it about 1 centimeter proximal to the aortic valve. I don't know if you can see as well on this image, but there's a little dotted line crossing over that's measuring the LVOT diameter. All right, so that's less important for us to measure. What's more important for us to measure is the LVOT VTI, which is the velocity time interval. Some of these views may look a little unfamiliar to most, the apical 5-chamber view and the apical 3-chamber view, but that's where you're going to be able to visualize your LVOT the best. And I put those green lines to show you sort of like the angle at which you're going to be measuring. So, quick review, apical what? I think most of us are familiar with the apical 4-chamber view as part of our echo imaging collection. So just to sort of orient you to how to get these specific views, you want to get to the apical 5-chamber view, you want to fan your probe anteriorly on your patient, and you're going to bring in this extra sort of tract in the middle, and that's going to be your aortic outflow tract or your LVOT tract, and that's where you're going to put your Doppler. Alternately, if you want to do the apical 3-chamber view, you can start with your apical 4-chamber view and then just rotate your probe 90 degrees for marker sort of up. All right, and then you'll get this sort of like truncated view where you're only seeing really one ventricle truly in full view, and then but you'll be able to visualize your outflow tract. So I'm going to give you another thing that flows traversing valves or chambers with the heart are the same, except in situations where there's a regurgitation or a shunt, because you have different directions of flow. So if all of that just went over your head, or you're like, this is too complicated for me, theoretically, you can get VTI from the apical 4-chamber view because you can measure the flow across the right ventricular outflow tract or the mitral valve. So this allows people who are maybe like, I can't figure out how to get to the apical 5 or the apical 3, but I still am interested in this flow. You can measure it in a more familiar view that you have. All right. So getting into the nitty gritty of actually how to do the trace, you're going to find your 5 or 3 or 4 chamber view. You're going to find your left ventricular outflow tract or your right ventricular outflow tract or your mitral valve tract. And you want to position your little Doppler signal at an angle of less than 20 degrees from sort of 0 straight vertical for ideal measurement. When you hit your like Doppler signal, you're going to bring up these waveforms on the bottom that you'll then freeze. You can go into like calculations, select VTI, and then you get to do some freehand drawing. And you want to trace one of those little waves going downwards around, and that'll give you a measurement. You're looking for best points for a hollow wave, which shows up here. So if you see that there's sort of this white tracing on the outside and a little bit of dark on the inside, that's what we call a hollow wave. I like to think about it as like a stalactite in a cave. And then if you're doing it correctly, you want to average 3 measurements for any patient with sinus rhythm, or 5 measurements if someone has arrhythmia. This is a lot to remember. So there's actually a tutorial coming out with like step-by-step pictures that we can send out to the whole residency in case you want to do this the next time you have someone that you want to fluid this on. All right, some more numbers I'm going to throw at you. The normal VTI is 18 to 22 in a single measurement, but we don't really care about what a single measurement is. We care about the delta measurement, the change before and after your intervention. And the change that you're looking for is a 12 to 15% change or greater. That's going to show you that you're fluid responsive. All right, so now that we've gone over all of that, we're going to go over a case. So we can sort of walk through how to use this. So this case is a 60-year-old female, hypertension, heart failure, EF of 25%. CKD, coming in with fever. The vitals don't look great. She's febrile, she's tachycardic, she's hypertensive. She's satting okay on her mirror, and her EKG shows sinus tax. This is probably something that's going to be rolled through like CCT as a sepsis clearance or a sepsis code. And nowadays, we're going to call the sepsis code, get everyone on board. We're going to draw the labs, put in all these orders. You as like CCT senior or junior, you're gonna be like, this person has, an EF of 25, but she's febrile, she's hypertensive. Maybe we'll start with a 500 cc bolus. There's some time for that. Just a thought. Some people, I think, might clear her to pod A at this point, depending on how your CCT looks versus how the pod looks, depending on which attending you're working with. Other people might decide to keep her. Let's say you keep her and said you want to get a little bit more information. You have the ultrasound, you want to take some pictures. You do your bedside echo. It's pretty much remarkable for what you already know, a severely reduced EF, but not super high yield because all the other views. You look at the lungs because she has CHF, and you want to make sure that fluid overloading her, and you see some scattered V lines, but no pleural effusion. So there's some fluid there maybe. And you can't get an IVC view because she's too big and doesn't tolerate it due to like pain. But because you're able to get all those echo views, we're able to measure an LVOT, and it ends up being 12 centimeters. This is all prior to starting your fluids. So this is, again, a number that you just sort of write down. It doesn't really tell you much with the first measurement, but it's going to help your calculation after your second measurement. So now this patient is after 500 cc bolus. Her blood pressure is a little bit improved, still pretty low. Her heart rate's a little bit improved, still tachycardic. And then you repeat your LVOT VTI. It's 15. I did the math for you. 15 over 12. That's a 25% increase, which means, yay, she's fluid responsive. You're doing the right thing. She's on that left side of that Frank-Starling curve. She has a little bit more to go. So now I think most people would be like, all right, let's give another 500 cc bolus. And now you can think about maybe clearing her because you've gotten a little bit of a picture of her fluid responsive status. You've done all your initial interventions. You're just going to wait for everything to come back. Maybe you have a savvy resident. Maybe you put in your clearance note what the VTIs are, and someone in the pod picks her up, or maybe you keep her in the hallway because, the pot is blowing up and CCT is kind of chilling. Either way, after a total of a liter has gone in, the repeat blood pressure is better, but still not great looking. Heart rate is still better, but still borderline tachy. You repeat your LVOT VTI one more time, it's 16.5, and at this point, you're at a 10% increase. Remember the magic numbers that were is a greater than 12 to 15% increase. So at this point, she's no longer fluid responsive. So if you're concerned about that blood pressure, we haven't even talked about her mental status exam, you may want to consider early phase in this case instead of giving more fluids. So I know it's drilled into our head the 30 cc's per kg bolus for anyone in sepsis, but this is a way to sort of see where they actually are on the Frank-Starling curve and take a more informed approach to resuscitating your patient. We're going to circle back to this Frank-Starling curve with the emphasis that we want to avoid fluid overloads. There's a lot of lines and numbers and letters here, but the Frank-Starling curve is that same green line that we saw earlier. That's represented sort of on the bottom. And then those two lines, the blue line and the orange line on the top, those are measuring your extravascular lung water. Some people look for that in terms of like B lines on ultrasound versus like pulmonary, like vascular congestion on chest x-ray. And the idea is that especially in those patients that are prone to be fluid overloaded, you want to stay on the sort of left side of that Frank-Starling curve, that green curve on the bottom, so that your extravascular lung water, that blue curve, doesn't start shooting way up, because that's where you're going to get increased morbidity and mortality. So again, a review. Green means go. So if you're in this is maybe a little confusing because it's on the right side of the chart, but lower down in the chart, when you haven't given as much fluid, where your stroke volume is not as high and you have room to go. So sort of like where those A lines are, that's where you want to be able to go from A all the way up to that first like pink dot. And that's where you're going to get the greatest increase in cardiac output. Then in that sort of small increase in cardiac output section where your curve is starting to flatten out, that's where you want to like slow down, maybe hit the yellow light, and then definitely when you've already flattened out on that Frank-Starling curve, you definitely don't want to give any more fluid, because that's where your extravascular lung water is going to shoot way up. So ideally you want to tank them up, but not over. All right. Some pros and some cons. I think the pros are pretty self-explanatory, as with most ultrasound techniques, non-invasive, pretty inexpensive. You can use it at the bedside. It's pretty available, at least for us in our resource environment. You can repeat it a bunch of times. Fairly reliable, pretty quickly interpreted. You don't have to do that many calculations, but there are some limitations on the right. So these are situations basically where you have valvular regurgitation or asymmetric ventricular contraction. Certain cases, like if you have severe hypopnea and ventricles are collapsing, where you have like septal hypertrophy, like in HOCM, where different parts of your ventricle are basically contracted like differently, then you're going to get skewed measurements. And as with all sort of ultrasound techniques, it can be difficult to get good windows in obese patients. Some people might be wondering, like, are we going to be good at this? This sounds really complicated. I don't know if I'm going to be able to do this. There's two studies that looked at this. The first one, sort of a general study, this was with ED attending, and they basically said ED physicians are as good as certified cardiac sonographers at measuring LVOT diameter and VTI. I think the one more applicable to us is the second study, which actually looked at residents and fellows to see how quickly they could get scans of adequate quality and what percentage of the pictures that they took were pretty good. I think it's kind of hilarious that the junior residents are a little bit faster and have a little bit better percentage of scans of adequate quality, but the fellows obviously make us all look bad. The takeaway I want you to get from this slide is that it pretty much only takes 3 to 4 minutes to get good images, which is not that long, especially if you're trying to make a clinical decision. So quick summary, you want to avoid fluid overload, especially in your patients that are prone to fluid overload. The way that you can avoid it, especially in someone that you want or are interested in fluid resuscitating, is to try to get a sense of their fluid responsiveness. That's why you're going to be measuring the VTI. You can measure it at multiple places. So if you're savvy enough to get an 8-5 chamber or an 8-3 chamber view, go for it. If you're more comfortable in the 8-4 chamber view, then you can measure it at the RVOT or the mitral valve. You want to calculate the difference in your VTI before and after an intervention, usually a 500 cc bolus, or if your patient can tolerate it, maybe you just put those legs up to your measurement. That'll tell you if you can get fluids. The key numbers you're looking for are greater than 12 to 15% for someone to be fluid responsive. Be careful if someone has known like heart problems like regurgitation or HOCM, something that would cause like asymmetric ventricular size or motion, your measurements are going to be off. And then we can get pretty good images in 3 to 4 minutes. If you forgot everything that I went over in this PowerPoint, there's actually a really good 5-minute sound video about this. All right. Thanks to Drs. Hannison, Maria, Cutright, and Kilpatrick for helping me with this slide. And thank you to you guys for making it through another kind of math lecture. Those are my sources. Yes?
Sorry, forgive me if I missed it, but did you mention anything about the diagnostic accuracy of this and any studies, sensitivity, specificity, like your ratios, any impact on outcome? I mean, being just plain devil's advocate, is this another fancy ultrasound thing measurement that doesn't mean anything? Like
I would say yes, it is probably at this point considered another fancy ultrasound measurement in terms of the evidence for patient outcomes. I would say most of the papers and sources that I read for this lecture were not necessarily looking at that. They were more going off the idea that we know if we just sort of blindly bolus a lot of fluid with the standard like 30 cc's per kg sepsis protocol, that people with underlying medical issues like that make them more prone to fluid overload may suffer increased like morbidity and mortality. And the way to maybe avoid that is by looking at the status.
No. Yeah, I mean, like most ultrasound research, unfortunately, it's it's either so simplistic that it's trying to validate itself by definition. Oh, great, we have this great thing that we measure VTI changes. We have a proven change in cardiac output. Okay, of course, by definition, yeah, I got the cardiac output. So either that's useless, or they go too far with it and they try to extrapolate. Well, with the VTI change, and our outcome measurement was mortality change. Wait a minute, is that really why we're doing this either? Like, do we expect to have a real change in why people are dying or not? Or are there different outcomes in between those extremes that you can instead? So, once again, like he was asking me, I always try to hope there's some study I've missed that is a holy grail that says, yes, your life-calling ultrasound has merits, do this, keep the residents, and they'll have better patient care because of this. It's not out there. I don't think it's been disproven, that hasn't proven either. So at this point, it becomes yet another thing in the toolbox you can try and maybe look to the future and actually get a right study that either says it is useful, perhaps. Traditionally, I think maybe for trying this lecture, because it is more advanced, it's usually one that we only focus on as a technique for our ICU fellows. And when we have focus on the fellows again, because it is a different way of thinking about how you're doing the reset. For other reasons, we mentioned IVC and social resonance is you still want a static image. Someone's coming in, you have a plan of like a diagnostic pathway, not a research pathway. I'm seeing this human being in front of me, you can't breathe, if you're looking awful, is it just initially off the bat, like completely overloaded, or are they completely like drained, and then we're gonna kind of treat this. And this is kind of that next level when they're receiving it in the ICU from us, and try to have a more nuanced. Well, now I don't care about one static image, I'm looking for a change. And where am I in that starting curve? Are this filling up with extravascular lung water? If I give them any fluid at all, and so I need to rapidly switch suppressors. So it's kind of hinting at that next level measure upstairs. Is there a perfect study that shows we can avoid intubations that people that carefully look at versus I'm not sure how non-sonographers look at polyrecess with serial capillary refill exam, what you guys do. But anyway,
I have questions whether VTI are related to cardiac output because what if the response to VTI with changes the heart rate? I mean, stroke volume changes the heart rate.
Mm-hmm.
So if you don't account for that, so if I give someone who's volume depleted some fluid, and I measure their VTI before I give them, and then I give them fluid and their heart rate drops, how does that affect their VTI? Because the stroke volume
it
increases
would
because
be
the heart rate
more,
increases.
the heart rate would be more rapid to begin with because of the bias contest.
Right.
Response, like contractility, get that out. And then as we get more volume, they relax.
So how do you control VTI to change the heart?
Let's see. The IA change, I don't think it would be because it's not at that level. It's not looking at. It's not.
Can you go back to the equation?
Correct. Like,
To that equation.
That you could say what would be the
No, I mean, the heart rate changes and diastolic filling time. So the stroke volume.
Froze.
Yeah, when the VTI is just looking at individuals. So that's why it
So it
doesn't
has to
matter.
measure stroke volume.
What's that?
It measures stroke volume.
Once you do the rest of the calculation, you get 2 stroke volume from it. But like this whole delta is just looking at, if you go back to.
but it's directly correlated with stroke volume.
Right. But I'm saying the stroke volume changes just with heart rate.
Well, stroke volume is how much can you express with each individual contraction. So the heart rate doesn't matter at all.
No.
It's when we get to cardiac output.
No, because the slower the heart rate, the higher the diastolic
But he's saying the aortic area is not going to change.
Yeah, that's like a shape.
And
The stroke
so,
volume, it should just be, then it's really, we get going towards, with the heart rate, you're trying to do the cardiac output.
Robbie had a question. Go ahead, Robbie.
Oh yeah, can you hear me?
Yeah.
Yep.
So we talked about for fluid responsiveness, but could you just use this for other things like if you're using just as a surrogate for cardiac output, can you use VTI to categorize like the type of shock you're in? Like, could you say like, oh, this patient is in cardiogenic shock? I guess it's hard because you don't have a baseline, but is there any other uses for VTI besides for fluid responsiveness? Like, could you use it for seeing if different meds help improve cardiac output, like pressor choice, stuff like that?
Definitely, yes. I think cardiologists use it a lot to do a lot of these calculations of stroke volume, cardiac output, and it does have some use in terms of measuring how much you can increase cardiac output with pressor use and sort of like uptightening pressors to a point where you like sort of max out your cardiac output.
maybe jumping off of what Sinner was saying, if you take VTI times heart rate, it would give you maybe a better proxy for cardiac output and variation in like something that takes into account that lowering heart rate would be increasing stroke volume from increased diastolic filling. And that would give you a better understanding of how much actual like perfusion is occurring and a better corollary to the math than just the VTI alone. But that's not probably studied.
I just actually had a logistical question. Like in your case, after the second 500 cc where you got like the 12% change, are you doing the VTI from 0.1 or 0.2 compared to that 0.3?
Sorry, so from the immediately previous
One. So it's like previous to previous, not initial to most current.
You only look at your delta. I mean, the only potential benefit from this is looking at what did I do from last time I did.
Yeah.
Point B, all right, like my was my intervention to get some fluid. Point C, be, oh, that's what it is. Okay, very point B to say what I just did was the score had merit.
Got it.
And so,
Okay. Cool. I thought that was really interesting concept. Thank you for giving this
it's
lecture.
definitely interesting. Definitely what I, preach the residents would be, don't get too crazy about one individual measurement or one even type of like workup here. So the multi-organ approach, always thinking of like NIC or change in relation to that cardiac output, your echo, in relation to the lung, like ultrasound. Is edema building up? Having kind of these multi-system approach, like we were trying to figure out the shock and like resuscitation, and have a lot more merit. Trying to find one in isolation. So that'd be,
Yeah, and I think that's kind of the point. A lot of people have trouble finding the IVC. Sometimes there's like gestalt in the assessment, and I think the point of this is here's another extra point that you could use in the picture to guide you.
Yeah, for sure. I think I wanted to talk about it with like fluid resuscitation because that's probably the most immediately applicable that I could think of from residents in the ED, but there's definitely a lot more applications and there's a lot of papers sort of proposing like, do you combine this with like your rush protocol to maybe do more diagnostic thinking about this cognitive shock.
Yeah, great talk, Lainey. I think one great application of this exam is actually to know when to start pressors. A lot of times we start pressors without adequately resuscitating patients. So you can use this exam, the VTI changes, you know that there can be fluid tolerance, but then when the VTI doesn't pass that 12% threshold, then you know that they're not fluid responsive anymore. That means the pipes are probably filled enough. And if you're not happy with their blood pressure, then that's the time to start pressors and not just keep flooding them with fluids and push them into fluid overload. A lot of times we just use IVC, which is good to see fluid status, but it won't tell us when the tanks are actually filled to the point where we should start pressors. It's quick. Me and Alec actually did it on a patient. Took only a couple minutes each time. We were able to guide the patient's care through it. So I think it's just another tool in our tool belt to help us.
That's definitely what I was cringe with is when you call for an ICU consult and over the phone, no one can look at the patient and say, oh, I have hypotensive. Oh, just give him a liter, see what happens. Wait, you guys know nothing about this. See what that is now. Come down to the patient.
It's just before they ask for the surgery. And the neurology consult.
Let's say, oh, I'll take it.
The dietary.
All right, good job, Lainey.
Thank you.